First of all, I would like to thank Dr. Khalid Malki for inviting me to participate in this important event. And I also would like to thank Dr. Huda Raddadi and Dr. Mohammed Al-Saif, who are my two associate researchers in this study. I will touch on the important aspects of this study just for the sake of time. I have no financial interest or apparent conflict in any device mentioned or product in this study. Our study on MyoRing was done on 156 eyes. It involved 132 patients, 72 of which were females and 60 were males. The patients' ages ranged from 14 years of age to 48 years of age. The average or mean age was 23 years. Follow-up was from 6 months to 48 months, about 4 years, with a mean follow-up of 1 year. We had in our study 4 rings explanted. 2 were explanted despite of good outcome due to overlying persistent epithelial defects. These 2 patients had a very advanced keratoconus, so the overlying stroma was quite thin, and due to the shearing forces of the eyelids, the epithelial defect persisted. So despite the good outcome, we had to remove 2 rings. 2 other patients had the rings removed because of unsatisfied results. So again, emphasizing what my previous colleagues mentioned, patients need to have an expected realistic outcome of these procedures. Patients without a realistic expectations can be unsatisfied even if they had a corneal transplantation done. So the methods done, all procedures were done by a single surgeon using the interlace IFS 150 Hertz. All patients had between an 8 to 9 millimeter pocket diameter with a 6 millimeter side entry wound incision. So as you can see here, the principle here is performing or fashioning a pocket, unlike the previous rings or segments more accurately described, where a tunnel is performed. So here we perform a pocket, and then the ring is inserted based on the Baracare principle of adding tissue to the peripheral cornea will flatten the central part of it. So all cases had the thinnest pentacam corneal pachymetry of 400 microns or above, and most cases had a minimal corneal pocket between 290 and 300 microns. Adjustments was done in 2 eyes, and this is again an advantage of the MyoRing. If the ring is not properly adjusted on the visual axis, you can always, on the slit lamp, after applying topical anesthesia and povidone iodine, you can readjust, or you can take the patient back to the minor treatment room and adjust the ring on the visual axis. Again, a second advantage of this ring is that if you get an under-corrected or an over-corrected result and the patient is unsatisfied, you can always take the patient back and replace the ring. So for example, if a patient had extensive flattening of the central cornea, you can explant the ring and replace it with a weaker ring. In our study, 4 eyes were replaced with weaker or stronger rings. No bandage contact lens were needed, nor suturing was done in any of our cases. Our routine for all our cases, we give Predfort and Zymer in the first week, and then we follow that with a weak steroid such as a fluoromethylone for 1 month. In regards to the rings sized, or the most ring used in our study, this varied according, obviously, to the stage of the disease. And we had to do simultaneous cross-linking in 21 cases, and this was basically due to the age of the patient. So patients we all know who are in their early teens or even late teens or early 20s, they have a more elastic cornea, and therefore have a higher chance of progression of their disease. So cross-linking was done in these patients. As you all know that rings and segments do not seize the disease, they only enhance vision with glasses. So the only, to date, available modality for seizing keratoconus from progression is called corneal collagen cross-linking. Of course, if the patients are in their late 20s or early 30s, we found that there was no necessity in performing a corneal collagen cross-linking, because from our observation, we found that the MyoRing actually slows down the progression of the disease. But having patients in their late teens or early 20s, they still have at least a decade in front of them for the disease to stop. So in these cases, we did perform simultaneous cross-linking. Most of our patients were from the north and west part of Saudi Arabia, though we did have patients from the central and southern parts of Arabia. We used the grading system, a modified grading system proposed by Albert Dexter, the Amsler-Krumich grading system, and we took into consideration, as you can see now in these tables, the grading system that we used as proposed by Dexter. We looked at the K2. When you do corneal topography, you get two Ks. You get K1 and K2. K1 meaning the flatter keratometric reading, and K2 meaning the steeper keratometric reading in the central 3 millimeter zone. So when we say here K2, we're talking about the steeper K reading in the central 3 millimeter zone, though we take into consideration the Kmax, and the Kmax doesn't necessarily have to be in the 3 millimeter zone. As you can see, as probably in most keratoconus cases, it is D-shaped or asymmetrical bow tie with a skew or a J-shaped type of pattern of keratoconus. So in the vast majority of cases, the Kmax is outside the 3 millimeter zone. So this nomogram is useful as a guide, yet you'll see in the coming slides, if a patient does have a very high Kmax, which is off-center, we do take that into consideration in planting a thicker or narrower segment. So for mild cases, we considered anything below 45 diopters as mild, moderate anything below 53 diopters, severe above 53, and advanced above 55 diopters. We, of course, excluded any patients who had Vogt striae. We know that patients who have Vogt striae have a very poor outcome. And we excluded, of course, patients who've had previous history of acute hydrops or central corneal scarring. So it makes sense then, for mild cases, we implanted either a 5 or 6 millimeter diameter ring with a 240 micromillimeter segment. And of course, as the disease grade advances, we go with thicker segments. We found from our observation that patients are more satisfied with the 6 millimeter diameter. This makes sense because the narrower the ring, the more the halos and the glare. Especially here in Arabia, many of our patients dwell at night and perform a lot of night driving. So this can be quite bothersome with the 5 millimeter. So you'll see in the coming slides that most of the rings implanted were the 6 millimeter diameter rings. In regarding to the most rings used, as you can see here in mild keratoconus, the ring most used in this category in our patient study was the 6 millimeter 240 micron ring. And as I mentioned earlier, is that we did use other ring segments because the Kmax determined that we go with a thicker segment and so forth, get a better result. So the nomogram is actually a guideline, but you should not strictly abide with the nomogram. For the moderate keratoconus with less than 53 diopters of K2, the rings most used were the 6 millimeter 300 micron ring and the 6 millimeter 280 micron ring. So it does make sense, and this result was not a surprise, that for moderate cases, we used the moderate rings. For severe, the rings most used were the 6 millimeter, the 5 millimeter 320 micron rings, together with the 300 and 326 millimeter rings. In advanced cases, and as expected, the ring most used was the 5mm 320 ring. This is actually the most powerful ring I have really observed out of all the rings used in treatment of keratoconus. The surgical technique is very simple. We use the femtosecond laser, but before applying the femtosecond laser, we mark the visual axis. So we ask the patient to look at the green light or the light of the microscope, and then we mark the visual axis as so, and then we fashion the pocket using the femtosecond laser, and then we create a temporal side incision, and then the ring is inserted. The ring can be slightly squeezed, but not over squeezed so that it doesn't break because it's made of PMMA. And then it is now the duty of the surgeon to centralize this ring on the visual axis. Not on the pupil, not on the geometric center of the cornea, but on the visual axis to get the best results. The thing with the MyoRing intrastromal ring implantations is that it does not have the wow effect of segments, yet it does have a very powerful effect. So as you can see here from the data that we've had, that the flattening effect is really astonishing. You can see patients were in their 50s. As you can see in K2, they flattened after 1 month up to 44 diopters of K2. So the flattening is maximum at the first month, and then it continues to stabilize thereafter. The visual recovery takes slightly longer time. As you can see here, in this slide, best corrected vision preoperatively had the mean of 20/60. Postoperatively, in our patients, it became 20/30, and you can see the range of these patients. Though flattening was very quick, so anatomical flattening was maximum at 1 month, visual recovery because of the pocket and separation and the inflammation of the cornea, which is expected, because this involves a pocket that involves the central cornea, it took up to 3 to 6 months. So in our patients, we saw that visual improvement was very minimal after 6 months. Sphere was immensely corrected more than cylinder. We observed at least 50% reduction in cylinder. So in conclusion, MyoRing implantation using femtosecond in keratoconus is an effective and safe treatment. It improves uncorrected and corrected, best corrected visual acuity significantly. It also reduces the spherical power, as mentioned, and the keratometric readings, and this was especially observed more than the astigmatism, though the astigmatism was reduced by at least 50%. And thank you for your time.